Our final speaker for the session is Dr. Alison Boast, who I've known for a little while now, but she tells me that she's deep into her PhD, studying bone and joint infections. And so she's going to give us some guidance, and I'm not sure if you want the handheld microphone to be singing about simply the best treatments for septic arthritis. Alison, over to you.
Thank you, Ben. We'll just get the slides up. Simply the best. So imagine now for a moment you're a parent and you're in the ward. You've just arrived back with your 3-year-old son. He's had a washout of his left knee after being diagnosed with septic arthritis. You gently try and lift him from the trolley onto his bed, and with a start he wakes. Before you can stop him, he kicks about, he's screaming, he's confused, and he rips out his cannula. There's a moment of heart sink for anyone who's been through this. Imagine now you've gently fallen asleep, you hear the alarming in the distance, but you wake a few hours later to a gentle shaking of your shoulder. It's a junior doctor who's come to tell you those 4 dreaded words, that they've come to put another drip in. And it makes you wonder, why do we need to give intravenous antibiotics for children with septic arthritis and many other common infections that we treat every day? So there are 2 enduring myths that shape our decisions that we make when we look after children and adults in hospitals, particularly when thinking about infections. The first is that longer courses of antibiotics are better. When you think about conditions like infective endocarditis or brain abscesses, we always treat for kind of 4 to 6 weeks. No one ever treats for 5, no one ever treats for 3. It's always a round number, and it's always 4 to 6 weeks. But why is it? Think about something like pyelonephritis that many of you would treat every day. Guidelines recommend treating for 7 to 10 days. How many of you, hand on heart, pick 7? How many round up to 10? Many of us think we're better at doing this than we are, and when they've done research studies to show this, the vast majority of clinicians always pick the longer number and they always round up because we want to try and do the best for our patients. We want to give them the best care and we want to prevent them from coming back from hospital. The second enduring myth is that intravenous antibiotics are greater than oral, and that will be my focus of the talk today. Infections are probably the most common reason that children are admitted to hospital, and intravenous cannulas are often the only reason that it's in is to give intravenous antibiotics. It's also very commonly the only reason that a cannula is recited during an admission. Children are often eating and drinking normally. They usually can take oral pain relief. So why is it that we put cannulas in a well-stable child during their admission? It's often to give intravenous antibiotics. So where did this myth come from? Back in the 1900s, oral antibiotics were probably the first safe and effective modern-day therapeutic. By the mid-1900s, the landscape of medicine was changing. We had intravenous medicines and antibiotics that could mean that infective endocarditis was no longer fatal and osteomyelitis was finally treatable. The clinicians who used these long courses of intravenous antibiotics wrote of their success in these large medical journals, and before we knew it, we had a dogma. To treat osteomyelitis, you need to treat for 4 to 6 weeks of intravenous antibiotics. And we've come a long way since then, but many guidelines still keep this dogma of the past. In these studies that they did back in the 1900s, many of them were uncontrolled. They simply wrote of the success, or they compared it to oral antibiotics that were inferior and ones that we wouldn't use today. But we learnt a lot since then on oral antibiotics. We know how antibiotics move through the body. We have hundreds of new antibiotics available to us. And I think it's worth thinking a little bit more about what is the difference between intravenous and oral antibiotics. Take this boy here. He takes a purple pill or antibiotic by mouth. It moves down his esophagus into his stomach and his intestine. It's absorbed and distributed around his entire body. Eventually it's metabolised and excreted, usually through the urine. And if you gave it intravenously, you'd skip that first step. But every subsequent step is exactly the same, no matter whether you give it intravenously or orally. And taking this one step further, we can look at how antibiotics move through the body over time. On the left, you can see a graph of drug concentration on the y-axis and time on the horizontal axis. When you take a medicine by mouth, it's slowly absorbed, peaks and then falls again. If you give it intravenously, you get that nice peak of effect. If you shade in that area underneath the line, you get what's called the total drug exposure. And indulge me a moment in some pharmacokinetics. So the concept of bioavailability is really important when we think about giving oral medicines. We want to know whether the amount of drug that's liberated and the patient is exposed to is the same when given orally or intravenously. In this graph here, you can see that they're roughly the same. That's a drug with good bioavailability. But look at this example. On the left, you have this lower drug bioavailability causing a lower drug exposure. Think back to those trials in the 1900s that showed the power of IV antibiotics. It wasn't a level playing field. They were using drugs that were poorly bioavailable. Imagine now, like a child in hospital, they don't just get one dose, they get repeated doses over time. And when that happens, you reach what's called steady state, where the amount of drug that's coming in is the same as the amount of drug that's going out. No matter whether you give an oral antibiotic that's been dosed appropriately or an intravenous antibiotic, you can achieve exactly the same steady state. So why is it that we keep giving medicine intravenously? When we think about the medicines that we have available now, we have a big list to choose from. Listed in green down the bottom are all of those magic golden 100% bioavailability drugs that we would say are absolutely equivalent to their intravenous counterparts. Think now about how many people in your hospital are on IV metronidazole, 8 hours. Why is it being given intravenously? In the yellow, we have our kind of still pretty good if dosed appropriately. So you'll see some familiar favourites like cefalexin and amoxicillin, and they still have very good bioavailability as long as we pick the right dose. And that is not the lower end of the dosing limit that's on AMH. Often the doses that we need to be using are much higher, so I would urge you to look at proper dosing guidelines for children that include the higher doses. And then we have some that we just don't use orally, so that's vancomycin. And that brings me to my first key message of today. The bug simply doesn't care how the drug got there. If you are a bug hiding in someone's body and you're exposed to an antibiotic, it cannot tell you whether it got there through a drip or by mouth. So there's no reason that we need to be treating infections with intravenous antibiotics. It's simply the same medicine. I'm obviously simplifying this a little bit. Obviously, an unwell child who comes into ED, you need that rapid action. For some antibiotics like gentamicin, which is only available IV, the peak is really important. But for most well, stable children, the bug just doesn't care how the drug got there. So why is it that oral antibiotics are best? So there's all the reasons that are pretty intuitive. Less drips means less complications, means less procedures, means happier parents, children, nurses. But then there are the other ones that you might not think of. So it means that children are more likely to go home from hospital. It also frees up nurses. So one study looked at the amount of time to give one IV medication, and on average that was 25 minutes. So for a nurse to go to the drug room, make up a medicine, get the flush ready, put it through the syringe pump, get it all organised, 25 minutes. Compare that to oral, where it's 1 minute. So imagine in your hospital if you changed 10% of patients from IV to oral medications. In one study it saved 100 hours of nursing time per day, which is huge. But surely this only works for those simple infections. It can't possibly be used for all the more serious infections where adults and children are given very long courses. Well, not true. So all of the infections listed here, so endocarditis through to brain abscesses, there have been landmark papers that have been published in the last 3 or 4 years showing just how equivalent oral antibiotics are. Even in neonatal sepsis, the RAIN study was published last year, which looked at completing oral antibiotics instead of intravenous in neonates with presumed early onset sepsis. So oral antibiotics, I'm telling you, are practically perfect in every way. There are a few caveats to that. So we know we need to think about bioavailability, so that's choosing those green or yellow antibiotics. Unfortunately, children won't take gross things, so that crosses clindamycin off the list. And we know that if you have to give it more often than every 3 times a day, it's going to be pretty tricky. Volume can also be pretty important. So cefalexin is an antibiotic that's fond in my heart because I use it for my trial. And sometimes children will be asked to take quite large volumes, but luckily for cefalexin, it's pink and it tastes quite nice. So as long as you sell it well, kids usually will take it. But volume can be a really important consideration. My next core message for today is the phrase oral step down. So as an ID fellow currently working in Melbourne, I would get many calls every day asking if they can step down a patient from IV to oral antibiotics. And I urge you all to cancel that phrase from your vocabulary and not use it. We're not stepping down treatment, we're switching it to oral. And it might seem like a simple change, or it might seem like it doesn't make a difference, but every time we tell a family, a nurse, a junior doctor that we are stepping down treatment, it creates that message that they're receiving an inferior or lesser treatment to intravenous antibiotics, which is just simply not true. So should we ever give IV antibiotics? There are a few exceptions. So occasionally, and particularly with the increasing antimicrobial resistance, we do have bugs that we just can't treat with oral options, and that is quite challenging at times. Sometimes kids come in sick and vomiting and they simply won't tolerate them. If they're malabsorbing, so have an underlying condition like short gut or inflammatory bowel disease. If they're unwell and you need that immediate effect. Immunosuppressed hosts are in a little bit of a different category, so we would tend to use more IV antibiotics. And then the last two, poor compliance and undrained collections, it's always a dagger to my heart whenever that's the reason that we recommend long courses of IV antibiotics, that sometimes you just can't get around the fact that a child simply won't take a medicine, or there's a collection that's simply too deep to be drained, and in those instances, sometimes a longer course of IV is appropriate. So I'm telling you that we should be using more oral antibiotics, but how do we actually do this? How do we change practice? We can do research. We need to translate that research into practice, and we need to educate others. And so in enters the BEST trial. So a lot of people thought I should call it the Boast trial, which is my last name, and I elected not to call it that, so it's the BEST trial. And this is bone and joint infections simplifying treatment in children. And this is a labour of love that is forming the major aspect of my PhD. We are taking children from sites around Australia and New Zealand, and we are randomising them to receive all oral treatment. So from the point that they are enrolled in the trial, which can be any time in the first 24 hours of their presentation, they are randomised to only have oral antibiotics. We're looking then to see what is the outcome. At 3 months, can we tell the difference? And we would like to show that oral antibiotics is non-inferior to the intravenous standard of care. We're also looking to see, how does that make kids and families feel? Do they have better quality of life? Do the families save money because they're in hospital for a shorter period of time? So many of the sites that you work at will have BEST starting or has just started. So please find out, and if you enrol anyone, I will send you a box of chocolates, because as is the way with clinical trials, recruitment is the trickiest thing, but we are certainly getting there as more sites come on board, and we hope that in a few years' time I'll be telling you that I can now say for sure that entirely oral antibiotics is non-inferior, not just for septic arthritis, but also for osteomyelitis. This trial isn't the only one going on, and I just wanted to highlight some incredible research that's been done in Australia. So we have the CHOICE UTI study that many of you will also have heard of, being led by Dr. Layla Ibrahim at RCH, and this is looking at treating complicated UTIs with either 1 or 3 doses of IV antibiotics. Again, trying to use more oral antibiotics and get children home sooner. There is the FOSUTI study. So some of you may or may not have prescribed the antibiotic called fosfomycin. Worryingly, we're using it more and more because we're seeing very resistant E. coli UTIs, and this is a great time to reach for this older antibiotic. There is a study now being led by Dr. Phoebe Williams in Sydney, looking at randomising children to receive fosfomycin versus standard of care, which is usually intravenous. And finally, the SNAP trial, which is the largest study ever done on Staphylococcus aureus bacteremia, which is including neonates, adults, pregnant women, and this is also looking at whether you can do an early oral switch with Staph aureus bacteremia. So what can you do when you leave today? So I think the message from today is that sticking to the status quo and clinging to dogma of the past can cause harm. Think about how many children we needlessly put in new cannulas when they're well and they're stable and they're improving. So when you next do your ward round, can you think about whether the child that night, if they're drip tissues, it needs to be recited? Can you document that clearly? Next time you admit a patient or you're doing a ward round, can you make a plan for an oral switch, not a step down? Can you choose articles in Journal Club which look at the use of oral antibiotics? There's heaps of evidence coming out in this space, and if you look for it, you will find it. And then finally, can you educate others? I think the core message from today is that the bug doesn't care how the drug got there, and that it's no longer an oral step down, it's an oral switch.